Welcome, and thank you for joining us for today's talk on the basics of accountable care organizations and the potential for integrative health in medicine. My name is Jennifer Oliovnik, and I'm the program manager for the Project for Integrative Health in the Triple Aim at the Center for Optimal Integration. Today's webinar is part of our first series, a short course on understanding the emerging Triple Aim landscape. In addition to today's lecture, we have two additional webinars planned. One will focus on patient experience and the other on quality and population health. I would like to take a moment to introduce our speaker, Karen Milgate. Karen Milgate is a seasoned healthcare policy executive with a deep knowledge of Medicare and Medicaid's policies, programs, and operations and data. For the last 2 years, she has provided strategic direction as an independent consultant to numerous provider, payer, and data analytics organizations on the current and future healthcare market. She is also a frequent speaker on the interaction between the Affordable Care Act and the integrative healthcare field. Prior to her consulting experience, she was the Deputy Director of the Center for Strategic Planning within the Centers for Medicare and Medicaid Services, the agency that runs the federal programs with over 100 million beneficiaries. She directed agency analysis and strategic planning efforts to improve these programs. Her specialties include a deep understanding of the quality, utilization, and reimbursement patterns in the Medicaid program and of Medicare and Medicaid's data sources. Ms. Milgate was a key player in 2010 healthcare reform legislation and has provided policymakers with counsel regarding ACOs, medical homes, innovative center models, dual eligibles, quality and efficiency measurement, and electronic health records, among others. Karen is also one of our PIHTA advisory team members. Welcome, Karen, and thank you for joining us.
Thank you.
Okay. It appears, too, that I'm having just a moment of technical difficulties. Just 1 second, please. And before we begin, I would like to offer a primer about our sponsoring organization, the Academic Consortium for Complementary and Alternative Healthcare. For those of you not familiar with ACAC, we are a broad, multidisciplinary organization. We advocate for 5 core professions, each with a programmatic accreditation body recognized by the U.S. Department of Education. Through our member organizations, we are linked to 375,000 healthcare providers, about 180 accredited institutions and programs. And we're also affiliated with traditional world medicine fields and holistic and integrative medicine organizations. The Center for Optimal Integration is a priority project of ACAC to facilitate advancement of interprofessional collaborative healthcare. The center offers a web-based platform that serves as a virtual gathering place for anyone with a stake in the integrative health and medicine movement. Additionally, the center houses 2 main projects, the Project to Enhance Research Literacy and the Project for Integrative Health in the Triple Aim. Today's webinar is part of the PIHTA initiative. So what exactly is PIHTA? PIHTA seeks to understand the overlap between the values of integrative health, so things like treating the whole person, supporting self-care, using least invasive methods first, and creating health. And it seeks that overlap with the goals of the Triple Aim, so enhancing patient experience, reducing costs, and improving population health. PIHTA has a few goals. One of the main goals is to continuously build out the most useful base of published research, high-quality gray literature, and examples from the field to support engagement and implementation decisions. Another goal is to assist decision makers in the optimal use of the values, disciplines, and practices of integrative health and medicine and meeting the goals of the Triple Aim. And we also like to feature experts in specific content areas to build interprofessional, multi-stakeholder communities. And today's webinar is a prime example of our community building efforts, which brings us nicely back to Karen.
Thank you, Jennifer. Can you hear me okay?
Yes, I can hear you just fine.
Okay. So before we go into the nitty-gritty of accountable care organizations and the juxtaposition between accountable care organizations and integrated health, I want to just give a little bit of context for myself and ACOs. I'm going to use the acronym CMS widely throughout my presentation, and I'm sure some of you know who CMS is, but that's the agency I used to work for that Jennifer talked about, the Center for Medicare and Medicaid Services. That is the agency that runs the Medicare program and then also the federal part of the Medicaid program. So it has a pretty big role in both how providers are paid as well as the manner in which the delivery system works, in the sense that incentives within the payment system, of course, have a large impact on how healthcare is delivered in the country. That program, the Medicare program, has two sides to it. One side is called the Medicare Advantage program, and that's where seniors will choose to be in a health plan, and the Medicare agency will pay a monthly fee to the health plan, and then the health plan does all the contracting with providers and pays providers directly and that kind of thing. And about 30% of beneficiaries in Medicare are in the Medicare Advantage program. The other side of the house is referred to as the fee-for-service side, or traditional Medicare, and that's where the Medicare program pays directly to providers, and beneficiaries can essentially see anyone who takes Medicare. There's no management or real control at all over who they see or what type of services they receive. So the accountable care organization, as an organization and as a reform, is really targeted at trying to put in the fee-for-service program, the traditional Medicare program, a little more incentives for providers to pay attention to what happens across the full continuum of care, and also to pay a little bit more attention to the dollars that are spent on health care. The Accountable Care Organization program was established. It's officially called the Medicare Shared Savings Program. And then there's also another model that's more of a demonstration called the Pioneer ACO program. They were both established as a part of the Affordable Care Act. So most people know the Affordable Care Act as the legislation that established the various programs to subsidize people to get insurance and establish the health exchanges and that kind of thing. But at the same time, Congress did a huge amount to actually try to implement incentives within the Medicare program, within the Medicaid program also, to try to encourage a more value-oriented way of paying for health care within those public programs. So the Accountable Care Organization was established as a part of that. While there are many demonstrations going on in Medicare at this point in time, this program actually was established as a permanent program. So there's no sunset per se. It is a part of the program, just like regular payment to providers is a part of the program. So we're going to talk about accountable care organizations today first, and then describe how it fits a little bit into this context that Jennifer gave us for the triple aim, and then go into some of the nitty-gritty about their quality metrics, cost expectations, and hopefully have some time for discussion about how integrative healthcare might fit into this model. So today we'll be talking about these 5 questions. I don't know, I need to go through them, so do you want to go to the next slide, Jennifer? So what are ACOs? So again, the ACO acronym stands for Accountable Care Organization. You need to go back. So there are a couple of, there's a significant requirements, but in terms of structure, there actually is not a lot of requirements around how the structure should be established. Essentially, the primary requirement is that there are a sufficient number of primary care professionals in the accountable care organization to care for the number of beneficiaries that are assigned to them. There's a minimum number of beneficiaries you have to actually qualify as an ACO, and that would be 5,000. Some ACOs are system-driven, that is, have more of a hospital at the center. Some ACOs are driven more by primary care practices or multi-specialty practices, but regardless of who is sort of the organizer of the accountable care organization, they have to have a certain number of primary care professionals to actually qualify. So they also have to be willing to take accountability for the overall cost and quality targets that are established for the aligned population. And I think before I go further, I want to describe a little bit what they mean by aligned population, because that's a really core piece that's important for understanding exactly how accountable care organizations work. So what happens is that an organization that says they are interested in being an ACO will provide CMS, the agency I worked for, a list of the physicians, primarily primary care professionals, who have agreed to be a part of their organization. And then CMS will look through claims data to determine which beneficiaries that saw those primary care professionals saw them for most of their primary care. And so essentially kind of defined, who is their primary physician, who's their main physician. And if it looks like from the analysis of claims data that in fact their main physician is one of the physicians that the ACO has said is a part of their organization, then they are considered to be aligned beneficiaries to that ACO. So what this means is interesting when you get to the third bullet, though, because the ACO has to be willing to take responsibility in the sense that there will be a target for cost, there will be targets for the quality of the care delivered to these beneficiaries, and they have to take responsibility even though the beneficiaries that are aligned to them are actually still in the fee-for-service program, meaning that they still have freedom of choice to see any provider they want, regardless of whether they're in the ACO organization or not. So some of their care will be delivered through accountable care organization providers, but some of them, their care won't. And so that makes it really different than the typical managed care model, where you pretty much have in-network providers, and there is a penalty if you try to see a provider that is outside of that network. So that sets up a situation for ACOs that is really a little more challenging in terms of managing patient care and coordinating care across settings than the organizations have who are part of the managed care program. So it's essentially a virtual network of providers, and those providers actually are still getting paid on a fee-for-service basis as well, and we'll talk a little bit about what kind of tension that creates within the ACO. Can we go to the next slide? So why were ACOs established? There's a lot of different reasons why they were established, but the primary reason was cost concern. And then the next slide will say it's cost concern, but it's also what are we actually getting for the money we're spending. So we're spending a lot of money, it's growing, and yet we keep hearing about all these quality problems. So how can we actually change the incentives in the program to make it more cost-conscious, value-conscious, quality-conscious, and thus enter the triple aim. Don Berwick, who was the administrator of CMS for some period of time, and I'm sure many of you know his name, really, honed that concept and provided as a focus for the Medicare program and in CMS in defining what it is that we should be aiming for in our country as the triple aim, and one of those being patient experience, and that's making sure that within the healthcare setting itself, when someone needs care, that their experience with that care is really as good as that could be. And that both looks at the clinical proficiency of how care is delivered, also the patient experience from a patient satisfaction perspective. And then the cost piece of the triple aim is basically trying to make sure, if possible, that we can actually lower the increase of per capita costs in this country. There is a significant expansion in the percentage of our economy as well as the federal budget that healthcare represents. It typically grows faster than the rest of the economy, although recently actually it's slowed down a little bit. But still, with the baby boomers retiring, it's really a big issue in terms of the cost of care. So one goal of the triple aim is to reduce the increase in the trend of per capita costs. The third piece, for the Medicare program at least, is kind of a new one, which is also paying attention to population health. So the point there is you're not just looking at the experience of care when somebody gets sick, but thinking about the population as a whole and adding in the concepts of prevention and wellness, which are key to integrated healthcare, of course. But high on the agenda for all of Congress and the administration is cost concern. So healthcare is around 18% of the GDP. It's growing, and it typically, as I've said before, is faster than the rest of the economy. Medicare is the single largest payer in this country, thus its payer policy can impact what's going on in health delivery. And so the concept is if Medicare doesn't actually do something to address this cost issue, it's going to be hard for other payers to do it. Medicaid is also an issue. It's catching up fast and actually may surpass Medicare at some point in time. And both of them together are crowding out other federal priorities and other priorities in the country. And in the future, it doesn't look much better. Their projections are that there will be fewer workers in the future to pay for actually more people who are on these public programs, and that will increase the share of per worker income that's necessary to actually pay for these. Again, crowding out other things that workers might pay for themselves, in addition to the increase in healthcare costs for those workers as well. Go ahead, Jennifer. So what are the options for addressing cost concerns? Well, essentially cost is really just, you go back to your economics in college if you had it. It's price times volume. Historically, Congress has tried to control price. It's a big topic of debate every year, on how much providers are going to get paid for their services. But typically the medical system itself was in charge of volume. The Congress hasn't tried to do too much about the volume of services. They decrease the price, for example, or don't increase the price for physician care, but that doesn't mean that the part of the program that has paid for physician care has cost less. In fact, it's skyrocketed, as the theory is that physicians have actually tried to make up for that lower price by increasing the volume of services that have been provided. So it's more and more difficult for them to really control the overall cost with price. So the question here is, how can they create incentives for providers to provide less volume to counteract the fee-for-service incentives essentially for greater volume? If you get paid a fee-for-service for everything you do, then you typically try to do more things, at least as an incentive in healthcare. So let's think about volume for a minute. So one of the reasons they also want to get at volume is because there's a lot of research that has shown that, in fact, all these services aren't necessary or appropriate. There's huge variation in the utilization patterns across the country for similar populations, and some studies have suggested as much as 30% of the care that's delivered in this country may be unnecessary. I've done a lot of research on geographic variation, and there are variations even much huger than 30% in terms of the use of different services in different parts of the country, which clearly indicate there's much room to improve in terms of finding the right care, to be the right levels of utilization of care. And some care we actually know maybe are indicators of poor quality care, such as preventable admissions, in some cases cesarean sections, etc. So this has led to Congress believing that it's important to change the incentives in fee-for-service from volume, meaning you get more the more you do, to you are rewarded from a financial perspective if you create better outcomes. So the bottom line for the Accountable Care Organization within this strategy is that the CMS establishes targets for cost and targets for quality, and allows providers some flexibility underneath those targets to manage to actually, hit those targets, which is lower costs than otherwise would have been, and improvement on some quality metrics. And the incentives within the ACO structure is the ability to actually share in any savings that are created through their actions. So who are they sharing with? They would share it with CMS for the Medicare program. So let's go to the next slide, and we'll talk a little bit about how that's done and then get to quality. So as I said in the previous slide, the agency defines which population that ACOs are accountable for. Those are called the aligned beneficiaries through their use of primary care providers. So again, to review, if the provider they see most often for their primary care is part of the Accountable Care Organization, then they are considered to be an aligned beneficiary. The agency then establishes a baseline amount per capita. So let's say this is an average amount across the history or the historic experience of the beneficiaries that are aligned with the ACO. So I don't have it in my head, what the typical average is, but let's say the baseline might be $10,000 per capita. That's per beneficiary. And then in the future, they say, okay, well, given current trends or current rates of increase, we think that this population, given no intervention, will cost X amount, at a future time, either over 1 year, 2 years, 3 years, whatever the performance period is. So let's say they say, okay, well, I think that, it'll increase by 2%, therefore the expected increase would be to $10,200, over 1 year. And if for whatever reason the per capita is lower than that, then the ACO gets to share in whatever savings that generates. So let's say, the benchmark, they came in at an actual of $10,100, there would be $100 for every beneficiary that was aligned to them that they would then share with Medicare. Now, our last bullet here says there is also another calculation, which is how well they do on the quality metrics. So let's say they would have, I don't remember exactly what the share rate is, but they may get 75% of that $100 for every beneficiary if they are at the top level of their quality, and they may get 50% if they're not as high, that kind of thing. That's how it's calculated. So they actually get real money. So how will success be measured if we looked at quality? And here I'm this is the actual metrics that were in the first final rule, which came out in the fall of 2011. They've since done some changes to these, but the basic categories are similar. So these are from that final rule. I haven't updated it to the more recent, but again, the categories are pretty similar. So you have metrics on the patient and caregiver experience. You have metrics on care coordination, patient safety. One of the highly weighted metrics is whether the number of physician practices that actually have met the meaningful use standard for electronic health record implementation. You have a bucket of metrics that are preventive health, and then another that looks at-risk populations, which have a lot of potentially preventable admission claims-based measures in them. So how likely are these organizations to succeed? So here is some of what we know about these ACOs. So in the Medicare program, there are now 360 accountable care organizations serving 5.6 million lives. They're highly prevalent. They're in 47 states. These numbers are as of September 2014, so very recent. They're going to be opening up for a new period of performance in January 2015, so there'll probably be some additional ACOs that will join the program. This is a reasonably significant number of people, certainly in the Medicare program, to have sort of ramped up within 3 years. So a lot of interest. To date, the total savings, they just came out with these numbers, are $817 million. The program received $372 million of these dollars, and then the organizations that were a part of the program got the other $445 million. Again, you know, I didn't put the how many saved, how many didn't. There's a lot of complications to how the benchmarks are actually finally calculated, which some of the accountable care organizations feel that they should actually be able to get more credit. I think it's somewhere a little bit over 200 and some odd ACOs. There's some background noise. I don't know what it is exactly, but so there's roughly 200 and some odd ACOs actually received some of these shared savings. So a fair amount did not get shared savings, and so there is some concern over that, and CMS is kind of taking a look at what those, why didn't they, and what they can do to maybe improve that rate. The total, though, in terms of ACOs, there was a survey that was done by the Levitt Partners, and they counted 626 ACOs in the country with over 20 million lives if you include commercial payers, and there's also some states that have Medicaid ACOs. So that's a pretty significant number as well. Is it a tipping point in terms of whether all health care is going to be delivered that way? I don't know that we actually know the answer to that. However, there are also several other payment models that are being looked at: patient-centered medical home, bundled payment, value-based payment, where these all actually fit very nicely within the context of the accountable care organization. They're all fee-for-service ways of trying to implement some more value-oriented payment into a system where you're paying, you know, providers for individual services. And this bullet is always kind of a Pollyanna kind of bullet, but I would just say I feel like it's also the right thing to do. I have in my career, when I was at the Medicare Payment Advisory Commission and then at Medicare itself, the CMS organization, had many, many conversations with providers who felt like the way the system was currently designed, they didn't really have an incentive to do what they considered maybe the right thing for care delivery. For example, you know, when you're talking to discharge planners in hospitals, you know, and they say, well, you know, why don't I call the patient afterward or make sure that they get what, you know, they really should be getting when they leave the hospital? Well, no one pays us to do that. We don't have time to do that. Well, this was, you know, that's an issue. But when you have an incentive to actually keep people from being readmitted to the hospital, and it's a financial incentive, then there actually might be a little bit of money to have that person take that extra step to actually talk to the patient who's just been discharged to make sure that their transition actually did work. So it sort of provides the incentives for providers to really think more about the outcomes of care for the patient across the continuum of services, not just what they do for that patient within that particular setting. And it also makes them think a little bit more about preventing acute exacerbations from occurring in the first place, and that gets us to some of the prevention and wellness services that some of you all provide. My last point there, but it is hard. So number one, you're setting up dueling incentives in the same organization. So these providers that are in these accountable care organizations that can share in some of these savings if they do a better job coordinating care also are getting fee-for-service payment at the same time. So they have an incentive to increase volume. They have an incentive to decrease volume. So it does create some pretty hard conversations, and I think there's probably a couple, at least, organizations on the phone today that could maybe give us some more stories about that. It's also not necessarily easy to coordinate care across settings. It's not what the system has typically done. So we're creating whole new systems of following patients, of communication across settings of care, of asking hard questions about what is the most efficient care for this person. And the savings thresholds are not simple to meet, as witnessed by the number of organizations that didn't actually meet them in this program, and even though they put a lot of investment in. So let's get to the nub of what you came to talk to hear about today. So how can integrative healthcare help in this realm? Well, let's just look at the goal. The goal is better outcomes that lead to lower acute exacerbations and lower overall health spending. So you have multiple alternative disciplines that are sometimes lower cost. And whether they're lower cost or not, sometimes they're in actually great demand by patients, thus leading to a better patient experience, such as acupuncturists, naturopaths, nutritionists, community health workers, nurse practitioners, and on here. So if you have an incentive within your program to create better outcomes, including patient experience of care, and you're trying to lower overall health spending, number one, if you know these things work for that kind of thing, and they actually might cost less than some of what you already provide, and I know that's not necessarily something you can claim overall, you might want to try to think about other ways to deliver some of the services that you've already been delivering. For example, certified professional midwives or birth centers are alternatives to hospital births that often will lead to the same or better outcomes than if all your births are done in the hospital with OB-GYNs. They tend to be more patient-centered. Often integrative health care addresses more than one issue, so there's a lot of twofers to be had. And as I said before, they have been shown to improve the patient experience of care. And there is one part of their quality metrics that are our patient experience of care, patient satisfaction measures, and they are actually a fairly significant part of the overall quality reporting score. So it is an important aspect. Let's go on to the next one. So what I have been talking to various organizations about is really thinking hard about how your practice or integrative healthcare discipline can fit into this model itself, or how could a variety of options altogether impact healthcare within this model. So, for example, we heard a great example at a meeting I was recently at from Alina talking about, a variety of different modalities that were offered to patients. So it wasn't just one or another or, a specific intervention for a specific problem necessarily. There was a whole variety of options that were available, and there were over time ways in which the conventional medicine system was learning what might be really useful for which patients within that array of choices. So the questions here, if a higher percentage of care was integrative health care, what are the potential savings for an ACO? What are the potential quality improvements for an ACO? Those need to be asked and answered for whatever your proposal might be. For a group of interventions, for one particular one, that's kind of the question that needs to be asked. You also need to find out whether there are ACOs, either Medicare or commercial payers in your region that contract in this manner. There's a list of ACOs on the CMS website, which you can go to see that. And then figure out how to make the case, create the models, and document the results. I want to say just a word about documenting the results. So one of the issues that I've seen over time as I've become a little more familiar with the so-called evidence, or I shouldn't even say so-called, but the evidence for integrative healthcare disciplines, is that there's this, really hard bar to reach of the randomized controlled trial, which, over time, I think there's more and more people saying, we really need to just look at broad observational results to see how things work in the real world, or at least that's really a critical piece. Well, trying to actually, get that kind of information is difficult, but in some ways we've created the opportunity here for a natural experiment, so to speak, with the ACOs, where you have a whole population you're accountable for, and if in fact there was a model that, wanted to look at or observe, okay, well, what is it like for patients that use this type of care versus patients that don't, you can actually document some really nice results that way and build the evidence base from an observational perspective. Go ahead, Jennifer. So this is a chart that John Weeks and I have sort of worked on together over time. The rest of it's on the next page of this. And this is kind of tries to list to some extent the goals that I know about for accountable care organizations across the top, and then the various practices or disciplines on the left-hand side. And the work is to actually look at your particular practice or discipline, or think of it overall, or different mixes and matches of those, and how they might impact what we know are the populations that need to be managed for the points in time of care that need to be better managed. So I have up there preventing admission to the hospital. So this is really critical in the Medicare population because this is where a lot of the money is. So there's significant dollars go into those hospitalization, and once a person is hospitalized and they're in the Medicare population, as many of you know either from working in healthcare or from your family members that they often have a huge amount of resources spent on them before and after and within that particular admission. So it's not just the cost and the experience of the hospital stay itself, but there's often a lot of care that is delivered afterwards to make sure the person is stable and doesn't need to go back into the hospital. But all through that process, because people in the Medicare program tend to be more vulnerable, they're older or they're disabled, they often kick off other issues. So things that can help in preventing the original admission itself, so you don't have that whole experience of care that ends up often creating more problems for people, or to prevent them from being readmitted. And that's something that's really a focus of hospitals today. You should know this if you don't know already. There are some fairly significant penalties now in the Medicare program for hospitals that have higher rates of readmissions than otherwise would be expected. So that's a really big focus for hospitals. So anything that you think that your discipline can do to really help manage people and keep them from being readmitted is important. Getting to know a little bit more about post-acute care, which is delivered in skilled nursing facilities or nursing homes, home health agencies. These are another source of dollars and variation in utilization in the Medicare program. Now, I have a lot of conditions up here as well. Those are probably easier for you to identify yourself in terms of working with people on these. So these are the primary conditions Medicare beneficiaries have. They often have more than one of these. These are often the reason they are admitted. So these are the challenges in terms of disease and conditions that those of you who are working in this sphere need to really address very specifically. So I'm just going to leave it at that. I think this is fairly self-explanatory, but I've used this as a reference quite often to really get people to focus on what it is the Medicare program and the ACOs are thinking about. So the next slide just continues on just to we've covered a few other practices and disciplines here. And then I've got a few examples here, and so just to get you thinking about, how you might think about this, and we're going to go through these fairly quickly. So first of all, in the joint replacements, we had there was a meeting down in Nashville I was at where we had a whole hour and a half workshop where we got various disciplines together and said, okay, so what are some of the examples of how you think you could really deal with this population? And one that stuck with me was related to knee and joint replacements, where they talked about actually for rehabilitation. After the operation, this gentleman was a physical therapist, and he said, but he also did Tai Chi with his patients, and those that he was able to do Tai Chi with actually recovered more quickly, were really excited about actually doing it, and he felt at least that it would lead to fewer people having to come back with any kinds of complications. So you can imagine some of these other disciplines would also be very helpful. My third bullet down there is just to be a tickler for, okay, so if you're going to claim there's some help for the ACOs, if your discipline would be useful for either managing joint and knee replacements or preventing them, what might be the kinds of statistics you might want. So those are my bullets here. You could prevent it happening. It might lead to lower lengths of stay within the facility they're in, rehabbing, maybe fewer complications afterward, improved mobility, etc. So those are the kinds of things you would need to document. The next example. Hypertension is one that I'm sure there's a variety of different people on the phone who would feel that it could actually impact high blood pressure. Number one way, again, would be to try to prevent the need for any kind of more intensive care by actually managing the hypertension in the first place. But after there is an acute episode, clearly there's other things that can be done to try to prevent any further exacerbation from occurring. So I just listed a few out that I think would probably work within that realm. And again, you would want to be able to try to figure out how you could document some of this cost and quality impact that lowering the blood pressure might lead to. The third one I added as an example just for discussion is pain management without prescription or opioids. And this has become more and more an issue for more of the under 65 population, but it is also a significant issue for the over 65 population, particularly in nursing homes. So again, this is there is some documented evidence around these kinds of practices and how they can manage pain without people having to take prescriptions. Clearly helping with some of the addiction issues that might be prevalent for all populations, really. So the next slide is just kind of okay, so this is where you need to think about what you might put on this slide. We don't have time to go into this in detail, but that was just sort of a tickler for you guys. So in summary, I think that this is really what I hope that that this country starts doing, that you all help do, and that we keep working together to try to really get solid under what is the case, both theoretically and statistically. What do these models look like? What works? What doesn't work? documenting the results so that we can really go forth and start telling the story, and that people resonate with that story because they've had some experience with it as it starts to sort of trickle out into the population. I will share one personal story just to show how I feel like this is a kind of an underground conversation, at least within the circles that I operate in. When I was leaving the Department of Health and Human Services back in 2011, one of the things I said to people as to why, because it was a surprise to people, had a really it was a great job. It was lots of interesting stuff to do. I talked to them about integrative healthcare and wanting to learn more about it and wanting to actually become a clinician in a certain modality myself. And probably, I would say 80% of the people I talked to had a story that they wanted to tell me about how some version of integrative healthcare had been important to them or their family in the last few years. So more and more people are experiencing this kind of healthcare and wanting it, but just not knowing how it fits into the system. And I maintain that it's our role to tell them how it fits into the system to the extent we possibly can. So I'm going to stop with the formal remarks here now and see if people have any comments, questions, or anyone want to share some ideas for how they have worked within the particular setting of care or in their lives to kind of integrate this kind of care into the more conventional system.
Thank you, Karen, for that overview and synopsis of ACOs and integrative healthcare. We have my colleague Deb Hill also on the call, and we are ready to field any questions that you may raise your hand, and we can call on you.
Deb, we have a couple questions
okay.
that came in here while Karen was talking, and I just wanted to get to those. I think one was in the chat area here. Can an ACO pay for services of practitioners who are not formally covered by Medicare to meet these goals? And if not, how can this apply to NDs, acupuncturists, massage therapists, and others that do not formally fall under the Medicare umbrella, I guess, is the last part of that question.
And can I ask who asked the question?
That was in the chat box. So
okay, so we don't know. That actually is a very good question. That is a question that I have actually been trying to make sure I have the answer to. So I have an okay answer. I don't have a definitive answer. So can they pay for it? It's a legal question because there is a law that I'm trying to make sure I know for sure everything I'm saying because I'm giving you a semi-legal opinion here. So I want to be cautious. There is a law that that was designed to limit providers from inducing beneficiaries from coming to see them through providing like free services. And so there's been a lot of discussion back and forth about, whether paying for these services, so if the ACO pays for it, is it considered a beneficiary inducement that they are able to actually pay for a service that the beneficiary couldn't potentially otherwise get from the Medicare program because it's not covered. In the ACO program, there was a waiver that was established from that particular law for some services specifically. It wasn't as specific for me to be able to say, oh, absolutely, yes, they can pay for anything. But it talked about services that were related to the provision of the other healthcare services, and that were incentives for improved quality. So, for example, the distinction was made between dollar incentives given directly to the beneficiary and disease management or care coordination programs. So it is a little bit in the interpretation. There is no solid yes or no on this, but because these services are directly related to healthcare provision and are designed only to improve the quality of care given to the beneficiary, me personally, I think you should be okay with it. But I didn't want to go into this legal issue specifically in my slide presentation, but it is an issue, and you may hear about it from either the organization you're in or otherwise. But suffice it to say, the ACOs that are out there today are not just providing Medicare-covered services. They're doing a lot more. So I suppose there's room to discuss it on either side of that topic. So I'm going to leave it at that.
Thanks, Karen.
And hopefully that was clear.
Thank you, Karen. Deb, do we have another question?
We have a couple of folks that would that have raised their hand here, so that's another option that we can use. So let me go ahead and unmute. First of our folks that wanted to ask a question is Bill Meeker. So I'm going to go ahead and you should be able to talk now and converse with us. Bill, are you there?
Yes. Can you hear me?
Yes. Perfect.
Okay, good. Karen Milgate, thank you so much for being on this call. I've learned a lot already, and have a couple of comments, I guess, and question. I'm the president of the Chiropractic College. I'm also an NIH grantee. I've designed and conducted clinical trials, published them, et cetera. And I've been doing this for about 30 years. And I guess my comment is that the discussion of how integrative healthcare gets into the system is much complicated by the confusion around modalities versus the discussion of professions. And since I know my profession the best, I'll just make the point that we are a profession, not a modality, and we, apply a variety of treatment methods. We're known for manual therapies, of course, but rehabilitation's in our basket as well. But we rarely get recognized for that potential, and rarely get recognized for other kinds of preventative things that we may also apply. So my question, and I've got another one, so try to hold on to this one, is how do we get that point across? Because, and here's the other part of it, is that it's been my observation that research is absolutely necessary, even randomized trial research, but is absolutely not sufficient to get the attention of anybody that's in a decision-making capacity, with some notable exceptions.
Yeah.
So in our particular case, making the case is not that hard. It's just it's difficult to find the audience. We need help to create the models and to document the results, but without getting in the door in the first place, it's really a challenge. And so my comment, my question is, ACOs are groups. Well, who are these groups? I mean, I kind of know, but if you could comment on how do you get into these groups, and how do you make that case? So there you go. Sorry for the long-windedness there.
No, it's such a good question because I struggle with that a lot myself. I pride myself on, if I think hard enough about a particular problem, I often come up with ways to move, and I have found that question really difficult, even though I've just given you a presentation saying you should go out and conquer the world that way, right? I mean, the ACOs are going to be large physician practices or conveners. So there's some some organizations that have taken it upon themselves to actually be conveners for ACOs. So those are sort of profit-making entities that are saying, I'm going to be the behind-the-scenes management for you. And they're hospital systems. Those are typically the three buckets. None of which you can imagine, and I'm sure you've experienced, are particularly open to this, right? They're not saying, oh, give me something else I can do because I don't really know how to do this. They are saying that a little bit, right? They're more open now than they have been in the past because there is some question of whether they have the right people, whether they have the right systems. I guess all I would say, at least now they have the right incentives, right?
Correct.
Which is one step, but it's an important step. In terms of, though, getting more specific about how to create the audience, I think we have to figure out the story. I don't feel like the story is well defined enough to know what to say even if you had the audience. So I'm still feeling like we're at the make the case and create the models to be even able to go in and talk about it.
Right.
One of the things that, for example, I have thought about this community and helping this community do is to put some sort of proposal together for how you document some type of, with and without integrative health care, this is what happens to a whole population, and have the Innovation Center at CMS do a project on it. I mean, no, I work with them on other projects. It's the furthest thing from their mind to think about doing that, but that would be one way, for example.
Sure. And I'm sure you're aware that in our case, at least, Medicare does cover chiropractic manipulation, but does not cover any of the evaluation and management activities that go around delivering that care.
I didn't realize there was that limit. I knew you were covered, but I didn't know the limit.
Well, it's extremely limited coverage.
Yeah, that is limited coverage. Yeah, your point about modalities versus profession, I think, is a very good one. Again, I think that the only way to deal with that is to really get the models that talk about how that happens and document it.
Great. Thanks, Karen.
Yeah. Very good questions.
Thanks, Bill. Thanks, Karen. And Deb, is there another question?
We have another hand up. I'm going to go ahead and this is Michael Sackett. Let me unmute you. And Michael, can you join us?
Yes. Can you hear me okay?
Yes, perfect. Thank you.
Okay. So, just saying hi to Bill. I am the Dean of the Los Angeles College of Chiropractic. Really, my question has to do with patient-centered medical homes. If I'm understanding correctly, these are another model, but within the traditional fee-for-service payment model. Is that correct?
Yes.
Okay.
Do you want to know more? That typically how those work is that oftentimes they will be centered around primary care professionals, or at least those professionals that do provide a lot of primary care. And they will oftentimes get a monthly kind of case/care management fee up front with either the assumption or the forcing of, savings paying for that on down the line. Now, sometimes they won't necessarily attach them, like there is the Perverse plan, the Blue Cross Blue Shield plan in the area in which I live does this, and they don't require, I don't believe, any kind of